whole healthcare industry is going to change dramatically in the next couple of years.
To chronic disease management and the preventative aspect of care.
AI can now understand the key clinical concepts of what's being verbalized in healthcare.
Welcome to Cherry Live. I'm Dr. Jordan Valrath, physician, entrepreneur, and Chief Medical Officer for Cherry Health. We're talking about Canadian healthcare. Join us as we speak to innovators, industry leaders, and people working to drive the health system forward. Today we are talking to Miriam Daru. She's a bilingual healthcare recruiter for Calian Health Services. She's worked with Calian since 2018, and she has personally recruited more than 100 physicians over her years. Prior to working with Calian, she was recruiting more generally for personnel from numerous industries, specializing in hard-to-fill roles, which I think is what attracted her to the physician and the medical space, probably being one of the hardest to fill roles. When she's not working, she loves to spend quality time with her partner and their very large family of pets. Her passion for art and continuous learning keeps her inspired and engaged. Thank you, Calian, for joining us today. Miriam, thank you for joining us, Miriam.
Thank you for having me.
So tell me a little bit more about Calian. Following up on the episode we just did with Dr. Ivan Ivanecki like a week ago, this might be a little bit discordant in when we actually published the different pieces. But so he was a family physician working on the military bases here in Canada. He had a fascinating perspective just in terms of the job itself and like how the system operates and all the cool things going on behind the scenes. And so Calian is the company that actually works with the Department of Defense and does all the recruiting for the civilian physicians on the basis. So I'm really excited to get your perspective. Tell me a little bit more about Calian itself. You guys have been around for decades now. It's a company that's like 40 something years old.
45 since 1982, actually. The general company started in Ottawa, and back then there was no necessarily divisions. So what I work for is mostly the divisions for health. So we do also provide learning. There's an IT and cyber solutions, and we also have advanced technologies. So each of those divisions has their own specialty. To their own degree involved with the national defense. They have been a major partner of the different work we do, but Calian Health has that contract with the national defense for about 20 years at this point. So quite impressive. Personally, I was impressed when I joined in, and that was kind of attractive.
Is there anybody else doing the same thing, the recruiting for the Department of Defense, or you guys have the monopoly on this area?
We have the monopoly. It's an exclusive partnership we have with them, and it's a great relationship we have with them. It just, from the company itself being built, there is a lot within our corporate teams. A lot of former military are using a lot of that expertise. So that's how that came to become a contract that we have with them, simply by the networking and the relationship we have with them.
Very cool. Very cool. And then, so the recruiting, obviously you guys are doing a lot of that, and not just physicians, but other healthcare professionals as well. There's other parts of Calian. This is sort of a giant company doing all kinds of different things, in healthcare and otherwise. So there's a learning division. There's the digital health side of things. Could you speak a little bit about to those and just sort of what Calian's doing in general?
Yeah. So if we get outside the health team, obviously we do that learning is where they work with preparing modules and recruiting for any individuals that will help with the training facilities within the Armed Force, where they have developed, let's say, within the digital expertise, some training modules and simulation systems for the armed forces that are proprietary now. There is also where we've developed some team with the IT and cyber solutions, where assuring that any network is safe and secure and there are safe practices. So there's a variety of things that we do that either touches on the nuclear or emergency management services. So lots of things whenever you think of defense, and management and project management, that's where we touch. And that's where health sometimes gets involved, and not just on a clinical level, but sometimes within digital health, where it's managing projects, where it's patient support programs, where it's psych assessment, let's say, for some correctional services, where they need to find the ability to police officers to return to work or to stay at work, and it's the mental abilities to work within whichever context they've been assigned. So we have a variety of things that we can use our expertise to not just provide support to patients, but even as any providers that may require support at any health level.
And so, what drew you to recruiting in the first place? How did you actually get here?
It's and if you ask any recruiter, to be honest, you fall on recruiting. It's as simply as meeting the right person. I went in for an interview for a totally different role, but my experience with event planning in sales, basically the CEO had a thought out loud and thinking, well, would you try? I like to try. It's something you can learn if you go in sales and if you like to talk to people and if you have a creative mind, it's a role that can be taught. Then it's a matter of learning the specific industry. So it really fell on my lap. It's not something I ever thought I'd do, but now I love it.
Clearly very successful with it too. You mentioned about 140 physicians currently under your belt for your recruiting statistics, which is no small feat, dealing with all the users on the Cherry Health platform regularly. So just the entire country of people that are out there trying to recruit doctors, and they are often 0 or 1 or maybe a couple, and you're in the triple digits here. That's wild.
Yes. Some community, they've heard of you, you've been contacted somehow, or there's about 8 of them. The network knows of each other. So it's quite impressive, the word of mouth, how quick it goes. But we get used to it.
What's your secret? How do you actually do it? For anybody out there listening who is currently at 0 doctors successfully recruited, how do you do it?
Honestly, it's a bit of outside the box thinking. The obvious post and pray is not really what works. For the most part, physicians don't look for work. They have work available. They have plenty options for practice. So it's finding a way to connect and keep it genuine. Just keep the conversation, simple. A lot of the time, it's a matter of patience. People are not necessarily to move right away, understanding that you have commitments to your patients. It's not a quick sale and close a practice to leave. If that's the case, a lot of the time I need to find the time to adjust my schedule. So it's really just ongoing conversation, keeping the lines of communications open for the most part. Some people take a few years to get ready, to get on board and just sometimes find other solutions than the obvious online. I find surprisingly, physicians love very traditional media, letters. Nobody sends letters anymore. People love letters. Physicians tend to respond pretty well to that. But basically any kind of solutions outside the box, social media with different kinds of ads and networking and attending events, really.
And really building up that network over the course of years. Because like you mentioned, right, maybe the doctor's not currently interested, but now you can follow up 6 months down the road, a year down the road, right? Things change. People are in different circumstances, right? And so just, it really speaks volumes to the building that network as opposed to just purely trying to drive a close on the deal.
Exactly. It's not for everyone. It's there's definitely 2 classes of where there's a high turnover and high response kind of recruiting, more reactive, but that's very, very long haul. And so some people find that kind of exhausting because it's not going to be right away. But a lot of people, when there's some portfolio, that's the way the market works. And that's the way that you have to adjust and no pressure. And then eventually it works.
And so outside the box thinking, right, you got to get creative in terms of getting in touch with them. It's kind of funny that sending letters is now outside the box thinking. That's like the most, old school classic way of doing things, but that's now it's a fancy new strategy. So you got to get in front of them. What do doctors or other healthcare providers, what do they tend to be looking for? When it comes to their values and how you guys are actually helping them scratch those itches and satisfy those needs, not just them, but their family. What are those things that are most important to physicians that you're seeing in 2024?
I would say mostly in 2024. Before 2020 might be a bit different. I've seen a different shift in what people are looking for in terms of satisfaction. I would say a lot of the fact that you can get a good work-life balance, like having time to live outside of your work, it not taking everything out of your energy and being able to enjoy that time off and really have that time off, knowing what you're committing to and having a time to really see your patients. A lot of time people find frustrations where they're no longer having as much time with their patients and there's a pressure to see a lot of patients with a certain amount of time and administering and managing a clinic. Sometimes people say, I thought I wanted to have, and then it's kind of taking me away from what drove me to become a physician is being able to spend time with my patients. And I find that's where people meet their goals, those contracts on the basis where those are really the driving factor in the type of practice they have is providing quality care and being there for your patients. So giving them the time to do that.
That's really cool. So it really is about just like giving them a happy life work balance, right? You're like doing good, seeing your patients, doing what you're trained to do, and then not feeling overwhelmed by it all.
Definitely. There's a lot of case where people would have had those insane busy practice and eventually they come back a few years and be like, I'm ready to settle. I'm ready to slow down. And that's usually what I have is people ready to slow down and kind of enjoy the pace of life. A lot of people saying, well, I want to be there for my family. I have kids and I've got to be able to take them and have my weekends off. And that's usually when we have people come back and realize like that's where I actually meet my interest in my work. And that's what we're here for.
Who do you say no to, in terms of the matchmaking process of finding a position and finding a suitable candidate? What are some of those like core fundamental incompatibilities that you've seen?
I find, and it's a matter of case by case, but some people that are motivated by just very competitive environment where they have to drive the revenue, where they have to see as many patients, and when they're more independent, obviously where they have to navigate a very structured environment. Like, we're no secret here that working within a military environment, you have to respect certain rules and there's a structure in place. And some people might not be able to mesh well with that, regardless of the experiences. Being able to fit that lifestyle it's not for everyone. Some people are just so used to working by themselves and it's very team oriented kind of clinic. So that's when I feel some people are a bit more self-motivated. I find they're not necessarily meeting the kind of personality that will work well or long-term with those clinics, and it might clash at some point.
Yeah, they sound like they'd be more suited for, just running and managing their own business out in the community somewhere. And they're more that entrepreneurial, trying to really build the business up. And that's sort of their primary motivator as opposed to like the patient care.
Yeah, or where they want to lead change and they think they're going to get there. And then they want to bring in new ideas where you're like, well, slow down. You have to take your place first. And there are ways. Definitely, we also have roles for people to do that, but there's a time and place. And it's not necessarily the best when people come in with that. Like, great, I'm going to get in the right place to make things happen. You have to kind of manage that expectations.
Working with the Department of National Defense here, obviously this is like a very large structured institution, right? They've been around for a long time and probably have some very, very clear-cut policies and regulations. How does the physician integrate with that, right? They're not actually joining the military. They're still civilians. So what sorts of things do they actually need to abide by or do differently that they wouldn't otherwise have thought of, just working in a community practice?
Well, the most part is just within process. They have to go through clearance, and a lot of members are not used to having to provide as many credentials. So because of our structure, we need to respond to contracts authorities where they ask. It says black and white where you have to provide X, Y, and Z paperwork, regardless of how you're used to practicing, where people have to wait a bit to get through the process, where there's some red tape you have to go through. And then that patience to get through that is not for everyone. Some people are calling and they want a typical locum where they're going to be ready to start next week, fly in, do that for a few months. And some people have to adjust to the fact that there's a lot of hurry up and wait. A lot of people have heard that. It is true. We need everything yesterday, but we need to go through each and every step and be patient, in between. What else I would say? Just the chain of command, but for the most part, they have their own ways to refer. You go through specific system and specialists in the occupational medicine front. It's not an environment they've worked at that capacity. So you might have worked in a civilian clinic. Obviously, you always get those WSIB cases where it's related to that, but then it's really learning on the spot the work they do specific to the trades that you're not familiar with. And that's something they have to get used to. It takes some time to get used to. They provide you the time. There's no expectations of you getting used to it within a week or two, but some people have just simply by nature being striving for getting up to speed right away. And I have to tell them, like, be patient with yourself. It will take some time. And some people take a few months to get used to it, and that's normal. Like, it's not the same. So simply on a personal level, some people can take it hard, and that's where they have to get used to.
Well, I guess, yeah, you are taking on it's essentially like a new specialty, I guess, right? It's like a completely different niche of patients with a unique set of conditions coming in. It's not something that there's like training required for prior experience ahead of time, but, be prepared to do some on the job learning.
Yeah. And that's the beauty of it, where you can't have that experience. And that's why sometimes like residents will find they finish their training, they do their exam, and they could start right away. And that's the perfect environment to get up to speed with that and getting that and bringing that to the community, because it is very niche. Like, it's a lot of men for the most part. Yes, it is diverse, but still very mainly adults. And I would say between 18 to 45, up to 60 sometime. But it is very specific population that you don't get to see that much of that in the community and such a concentrated level. So definitely something that you can bring outside and adapt whatever clinic and provide extra care for that.
What about for the providers themselves, for the doctors or otherwise? Is there a certain demographic that really tend to resonate with these like Department of Defense positions? Is it the young adventure seeker? Is it the more mature doctor looking for just turnkey lifestyle oriented practice? Who tends to be the ones that actually wind up picking up these jobs the most? You've done this for years. Is there any trends?
Yeah, no, there is definitely a trend. I would say just from our interest standpoint, like I said, younger physicians, because it's more reassuring. They're used to the structure of the residency program and being taken on, not having to take on too much responsibility, and that it's reassuring. It's easy to integrate. So we see a lot of the younger physicians, and then a lot of physicians that have retired sometimes and are not quite ready, and they come back and they want to do some part-time. We do have a lot of practitioners that are at the end of their career, where they're ready to retire and they want to slowly decrease their level of effort. And that's where we meet most of our demographic. And it does meet a lot with the fact that even uniform physicians, when they do release from the armed forces, when they're mid-40s or 50s, are still very much able to do the work, but they're used to that environment. And a lot of the times, that is another big component of being able to stay on board and continue on, knowing the network and knowing the way they operate, but being able to take off the uniform, also take off a lot of time where they do a lot of admin work and they don't see as many patients. So when they come back and they work on contracts with us, that gives them that ability to go back to this really what being a physician was to them at the earlier days. So this is what we see the most, but we can see pretty much anything in between. But that's the main trend, I would say.
And then you say contract. This is sort of a foreign word to doctors. We never see this. You either take on a panel and you're just, I don't even know what the word for that is. You start a practice, or you locum. What is a contract in terms of the actual job structure?
So the contract context itself is this. I don't call it a locum because it's not shorter term, but it's as similar as they would be assigned a location for a set amount of time. When we work on contract with the National Defense, we administer it, but the provider is basically as a sole proprietor, is independent. So they provide consulting services initially. So they don't bill the same way. They don't quote the same amount of work. They have less, I would say, like they're not an employee. They're not expected to follow the same process as an employee would. They're independent. They have their own practice. A lot of them have practice on the side. So it's not their full job. It's extra. Usually it's supplemental. Lots of people is to diversify, not necessarily as a main practice. So it's more contract work because you could do full year. You can renew. A lot of people have been on contract for many years. Dr. Evanaki is an example where they can decide to increase, they can decide to continue on, they can interrupt and come back. That we've seen a lot. But that gives you that freedom of you're not stuck with a return of service where some people have to stay. Once you sign on and you work somewhere, you have to stay. Where for us, it's you're here for a set amount of time, and when it's no longer benefiting you or you want to explore something else, you can continue on. So you're really independent. That's simply to cater to that.
Yeah, so the contract sounds the word itself almost a little bit intimidating. Yeah, it's scary, but you can quit just like any other normal job anywhere in the world.
Yeah, we only ask 10 days notice. That's basically it. You're not rostered patients, so you don't have to transfer them. So it takes off that load. It's more for like to readjust schedules, for us to find someone to replace you, and it's you're not in the same limitations. So it's relatively easy, to leave.
That's interesting. Okay, so it's actually a little bit more headacheless in terms of if you are to actually quit and leave your practice. I just finished recording an episode with the Rasky company about how you actually deal with your record management and just a lot of the headache that can entail if you don't plan things ahead. But that's not even an issue for you guys. This show is brought to you by Cherry Health, Canada's medical network where healthcare practitioners connect. Physicians, pharmacists, nurses, chiropractors, and all other healthcare professionals can sign up for free, start connecting, messaging with colleagues, or checking out job opportunities posted by thousands of employers across Canada. With dozens of healthcare-specific job filters and search options, we make it easy to advance your career, find your dream job, or line up your next locum with hundreds of new jobs posted every week. www.cherry.health to get connected today.
No, that's no concern. And that's what's beneficial to a lot of people is it's hands off. The clinic is managed by the National Defense and they're very well structured. They have everything ready. And so that you don't have to worry about those side things because really you're there for your hours to be senior patients. Once you go home and you're not expected to do anything else. So what else could you have to manage outside of that? So it's simple. We'll simplify basically the practice for them.
That sounds nice. Tell me more about the actual opportunities. Where can you actually go and practice on a military base in Canada or outside of Canada?
We don't do outside of Canada. That is reserved for uniform members or reservists in some case. So that we don't manage those members, but on contract in Canada for military, any operational base right now, there's about 32. If I'm not wrong, don't quote me on that, but I think there's 32 locations from coast to coast, BC, Newfoundland, Ontario, Saskatchewan. Obviously, some locations are a bit more recurring than others. And each clinic is very different. We have some that are much larger than others. They serve different populations of members. Some of them, it's a training base, or sometimes it's for recruits. You have much younger ones. And then in another location, you might have higher ranked ones with more complex cases where the mental health case is a bit heavier. So it really varies from location to another. So depending on where people live and what their interest is, we're not expecting them to relocate for us. They choose where they want to go, but there is options everywhere. There's some gorgeous remote locations that for people that are seeking kind of outdoors and working in different communities, that brings them to that environment that they would not have seen otherwise. And it's a matter of exploring Canada at this point.
And does it wind up being a lot of acute care, like more of a walk-in clinic style of whatever healthcare issues pop up, and then the actual military service members have their own family doctor back home, wherever home is, managing chronic things? Or how does that actually work?
So think of it as members tend to be relocated. So they will work on a base. They'll be posted at a location. They may work there for a few years and then they're relocated a lot throughout their career. So they don't really have time to be put on a list to see a physician in the community. So they don't have physicians in the community. They really are going to the clinic. So they provide, of course, the walk-in, what they call a sick parade. So for any kind of situations that may arise, for any minor acute or depending on what the situation and what the base is doing. But they do any follow-ups. There would be their family physicians. They are assigned to that patient for the duration of their stay. And then they would be able to see them for any ongoing conditions that may arise until they're relocated to another location. So their medical records then are shared with the whole networks of clinics that they have. So wherever they have come through before, whichever other providers they've encountered, they have their full records there and they follow them simply.
Gotcha. Okay, cool. And then in terms of choosing a location, like how many opportunities are currently open with Calian right now?
For physicians only, I mean, a few
Yeah, yeah.
hundreds, a few hundreds, I would say, just on my list. And I cover mostly Quebec, Ontario. And right now I'm sharing that with two other colleagues for the West and the East. A few hundreds just for physicians, but upwards to 300 to 400 overall for health.
Okay. And then where's the most
Mhm.
popular base right now? What's the in vogue currently?
What would you describe popular, as in where the need is higher or where people want to work the most?
Yeah,
Depends.
where people want to work the most, I'm curious about. You mentioned the recreation and the outdoor opportunities and being in different parts of the country. Like, is there one base that's the hot commodity that everybody's trying to get the jobs at?
Surprisingly, not really. Somehow, Toronto, which is a very small detachment, I basically never have anything to fill there. Some teams are just stable. There's no movement. A lot of people reach out about that location. There is a lot of the network. They're curious about it, but we don't have openings. And that happens a lot. Some people can reach out just randomly and say, I'm curious about this. And we don't have anything for them. And that happens. I would say wherever you have major cities, wherever we go to, it could be Vancouver, it could be Montreal, where Hello Physicians are. And usually within cities, you have such small clinics because clinics tend to be on remote locations, that they have lots of need on those remote locations, but you have to go. You have to be able to live in that area. And that's a bit more complicated sometimes to between the passion of going there and the reality of making it work. So I wouldn't say, I don't think there's one particular famous location. So
Okay, other than
we're
Toronto.
divided. Toronto, for some reason, yeah, I get a lot of people reach out from Toronto, and I somehow have nothing. From a clinical standpoint, I don't have much.
And then what is the process like? Let's say I'm interested. This sounds really cool. Then what?
And then what? Well, you would be normally assigned to a recruiter for the whole process. So wherever you're located. So I work, like I said, in Quebec and Ontario, and then that recruiter basically follows you through the whole process where we would coordinate any communications with the clinic. You have to go through a security clearance. So we coordinate that with the security department. So every instructions of here's the next step. So I would conduct an interview just to gain insight as to what they're doing. In some case, if there's no CV that's already present, a lot of physicians don't necessarily carry a ready detailed CV. So I would build that with them, and we would do simple reference check and coordinating visits. Sometimes a matter of seeing the location, meeting with that team there, seeing who you'd report into, and then if the setup works, do you see the people working there? Do you see a match there? We coordinate these things. And then you would normally chat with me. You would chat with a contract manager that usually is assigned to you once you're on contract, kind of representing you at Calian. So wherever you have HR related questions, they would be your contact. And that person would chat with them to assess personality wise, like quality on paper, fine. But do you match with the clinic that I manage? So each of those contract managers is assigned a set of clinic that they are in communications constantly for their needs. Coming usually from higher up, from D&D, but day to day, the clinics also have some needs that are different from what the ability to open a role is. So they are better suited to know, like, what really is a challenge there. What is the team like right now? Like, they come on site and they visit it with them. So we go through all of that. And basically I would have to present an official submission with all your malpractice, your licensing, your credentials being up to date on all front. Then we present that to D&D against a role, and people will say, well, I'm able to work a set amount of hours. And then we get approved for that set amount of hours and you're on contract. So nothing that would say exactly what day you work or how that schedule built. We don't manage the day to day. We really just administer and manage the contract. Day to day, you respond to a base surgeon or a clinical manager, if you want to call it. And you work with the team. They take care of your onboarding. They take care of your on-site training, and then the day-to-day work and signing caseload. And that's really directly with them, and who you respond to and what the parties are. It's not up to us. It's really with them.
So pretty formal process, but very handheld, I guess, throughout the whole thing.
I'm there through the whole process. They can text me. I have a cell phone. I have emails, like whichever works best, but I'm assigned to them until they're handed over their contract manager. Then they would have full contacts for whoever takes care of them, but I'm basically the go-to person until then.
When it comes to the security clearance, what do you need in order to qualify for that? Are they looking at your parking tickets, or have you ever seen a physician get declined their security clearance? How often does that happen?
I have not personally experienced that. The security clearance is a government requirement. So it's simply stating that regardless of what work you're going to do, you have a right to access certain things, but on need to know base only. So not that you're allowed to go check everything, is if you need to, you have that access. And there are different levels. We do reliability, very basic. And simply they would check, you need to just have lived in Canada and held an address in Canada for the last 5 years. You don't need to be a resident. You don't need to be a citizen. So some people can come from outside, but if they've lived here for more than 5 years, there's no reason they cannot be eligible. And they do, yes, a police check and a credit check, but very high level. It's not like you're manipulating money, so they're not worried on the same level. So very simple. They go 5 years back, and that one is held for 10 years. So once they're on contract, that's the one step that can take some time. I would say some people can return very quickly. Some people wait about a month. I've had people wait longer than that. So some people that would have been outside of country. It's not impossible. I've physicians that for some reason, I think it's Australia that allows physicians with a Canadian license to practice very quickly without obtaining a local, or very quick to adapt. So they're transferable. And she was able to work there for a full year and wanting to come back into Canada short of that. I think she was 3 years into the country. So there is a process. It's not impossible, but it can take a bit more time. And we were able to get it through, but it took about 6 months to get cleared. So some people don't want to wait and sit there, but for the most part, if you're patient enough, it's not a problem. It's a day-to-day thing, and anybody from admin then all the way up would do that. It's very standard for government contracts.
It sounds pretty similar to what they do just when we get our licenses in the first place in a different province. They just make sure that you don't have any pending arrest charges or anything like that. That's an obvious red flag.
Yeah. And like, are you at risk of being bribed? Are you at risk of committing fraud? Like, these are just basic things. And I've gone through the process myself. Like, sometimes people are not so sure, and I can send them the link, and there's lots of information about what really do they check, but it's very similar to when you get your license. And sometimes people are concerned, like, well, I've had that. How do they? You have to think of everything is just, it's a standard. It's not a matter of choice. We can't really pass certain steps. And that's when we see just through that process, when people start resisting that, it just tells me right away, when you're asking earlier, when you have to say no to someone, when they start to fight the process, you kind of have an idea that might not be an environment where you feel comfortable, simply because these are the processes. You can't go around them.
And then, okay, I've signed up, I've sat down with you, we're going through some of those initial interview pieces. What are those questions that you're asking me as the physician to figure out what I would be a good fit for, or some of those compatibility pieces?
Well, I like to know, the first is usually what drives them to work in a military base. So that's important to us to know that there is a personal value to them. A lot of times people will have an experience with the military themselves, or have family coming from. And I've had people say, well, my son just enrolled and I know they don't have the right support, and now I want to get involved. I want to see firsthand. And I feel like I have a personal interest in providing that care. Some people are what they call military brats. They come from that. They come from that environment. They've heard about it all their life. They wanted to do the base training, and then they kind of didn't feel comfortable enough. And now it's just going back to that initial interest. And there's different reason, but usually if there's a connection to something that drives them to work with that population, is usually where we kind of see a fit. So that's one major one. But otherwise, I would say in terms of clinical qualification, yes, a family physician has all the qualifications needed, but that environment will focus a lot on, obviously, occupational health that we've mentioned earlier, heavy on MSK. So people that are interested with active population that are active, they will collaborate lots with physio and orthosurgeons and such, and that's the kind of environment that is. So people that like pediatrics might not find their interest. And finally, I would say mental health. Yes, the reality is the population in general has an increased need for that, but specifically the way it's practiced at the base, the need is heavy. It's complex. There's a lot of waiting times even on base. So the need is heavy for that. Even if they do collaborate with the mental health team, and that's the beauty of it. You can refer internally. They have social workers, they have psychiatrists and psychologists. They work with addictions counselors in some case, depending on the base. But they do have a pretty wide team, but there is that level of trauma you have to consider when it comes to military, just from the lifestyle itself and the reality of them having to go to front in times to times. Yeah.
What do you guys do to help support, if I want to do some ongoing education or learning, maybe I'm feeling deficient, or maybe I just want to like top up my skills in some of these areas to be more competent and a better provider. How does that work?
Before getting on contract, you mean?
Or
it would
during,
be hard.
Or after.
During, I would say, well, when they're on site, they usually getting up to speed with the reality and the lingo they'll hear from just the general environment. There is always the opportunity to get sent on those more specialty trainings. So they're proper military training. So unless you've been prior military, you wouldn't have never gotten it. And I know on the civilian side, there are ways that they can train you for, let's say, evac and things like that to support some pilots. But in this case, we do work with a different specialty where there's a different trades associate and different occupational issues that can arise from that. So they do really train them at that capacity from a military standpoint. So that's an actual certification called flight surgeon. The need is always increasing, and you'll see that depending on the location of a base. If it's an air base, you'll definitely have more of that need, where you would then see those patients at that specific capacity with added training. And then you can also work with people that work in submarines and divers, where again, that is the environment is a bit different. There's a different pressure. There's a different access to things. The equipment itself can create issues. It's just the reality of the day to day. Not knowing firsthand what it may look like is hard to fathom, but just thinking of the fact that those environments can be different when they do deploy, and that there are some specific qualifications that they can train you on. So we do have set amount of civilians that can get nominated every year. Depending on the clinic, they nominate the physicians that has the right fit for that. And sometimes if the need is increased in that location, they can send you on that course from their first year. Some people have been on contracts for years without it. So it's something that some people can look forward to. So every year we receive a handful of names that get sent there to increase their knowledge. So people look forward to that a lot.
Yeah, so Dr. Igor Ivanecki, he had mentioned this, the dive certification and the aviation medicine is one of the coolest, opportunities that comes along with this. What are the different levels of that training and education? There was the basic aviation medicine, I think he mentioned, and then you can be the flight surgeon. That sounds like a pretty fancy title. Is there anything above that, or does that keep going?
I'm pretty sure there is, because we also don't have access to those other specialties that are usually used for those that are deployed and then work on the field outside of the base. Those I would not necessarily be aware of. Flight surgeon, as far as I know, is pretty high standard, pretty higher up in terms of certification. So they go through those basic training, and then there's advanced training. So usually you have to go through a set amount. And then those would be sent also on those recertification courses after a few years. If you're no longer up to speed, like there's no official expiration, because if you work day to day with those patients, you are up to speed. But then you can increase that. But other than that, civilians cannot really access those, what we call I think tropical medicine, and I can't remember those other ones. But there's a variety of other ones that they have access to that we don't. But they will work within the team that might have people with these qualifications. And it's always interesting, simply as within a team setting, learning from these people, from hearing their practice and learning from that. But it's not necessarily as formal.
Very cool. Very cool. And so the other thing that he mentioned, he really thought was like the perk, the big pull for him was sort of the time, the hours, the pressure, right? So he said it's actually pretty nice that you have like a reasonable 8-hour day, your appointments are longer duration than you'd typically be used to. You're not running sort of like a revolving door of patients, just like in, out,
Mhm.
in, out. You get to actually like take time, get to know people. How would you pitch it in terms of, those job perks and those job benefits? What are really those highlight pieces that you see as being the unique opportunity?
But I would say usually it's an environment we actually get to go back to the basics and the passion behind the medicine. It's really providing quality over quantity is really what it is.
Mm-hmm.
Being there for your patient from the get-go, being able to address everything, providing them a full scope support because you're not as yourself, knowing that you can refer your patients to other specialists, but you as a provider having access to that to be able to discuss and treat patients properly and from a holistic perspective, being able to get insight from those providers. So that's something people tend to want and don't really see day to day. There's a lot of issues with the system in the community where people are getting frustrations with providing the quality of care they need, and not just by having the time, but having the knowledge and the expertise and having more than one set of hands on deck and just having other people that they can kind of discuss and get some more feedback from and getting their insights into their approach. And that's definitely something that is appealing to a lot of practitioners. Yeah.
Well, it's tough when you feel stuck, right? When you feel like you're hitting a dead end with a patient case and you're just like, I don't know how to support this person. I feel like there's just a lack of community resources or access to follow up and specialized care for these people. It sounds like that's really like another one of the strengths of the actual on-base opportunities.
And I would say it's not that it doesn't happen. Like there is always going to be a point where you can no longer, you've reached your limit. And that's the reality we face with a more diverse population where there's limitations of knowledge and ability to serve a more diverse population, but they have the ability to reach out to subject matter expert within a team located in Ottawa where they do manage those more complex. And then it gets to that next level where you need to go further. You need to have more explorations of care. And if it gets to a point where ultimately you have to think of it as your patient is expected to be as healthy as possible to stay on duty. If it gets to a point where your patient is sick enough that there's no possibility to not just adjust to duty, but there's a release at that point that might need to happen. But before you get to that point, you would normally have access to a medical team that works for that specifically, not to all that is there to support at the clinical level where there needs to be more investigation and adding on specialty support, and then they can reach out to that. So they're expanding on that currently. There's been a lot of movement in the last year where they're increasing that ability to serve a larger spectrum of the population.
How does the clinic itself operate? Is it the same kind of thing we'd see out in the community anywhere in like a city or a small town, or is it like noticeably different?
I'm not sure I'd be able to answer that properly because I'm not super familiar with how it operates in the community. But basically, a slight difference people might see is that the main team, and depending on how large some teams are, but if I'm thinking of some of my clinics serve up to 10,000 patients, they'll be subdivided. So you don't have one clinic, you go through reception and it's all a team, but they're divide each of those into their own administrative team or their own groups of physicians that have their own roster of patients that they share. And then within that team, you have a team of nurses, you have a team of PAs. So physician assistant is a profession we see a lot within the military. So on the civilian side, we do hire a lot of those. And then they would collaborate with that team, and then to share the patient caseload. So when you're not there, another physician is able to support you, which you won't necessarily see. And that's where within that team, they do that. But each of those is able then to refer. So they have the admin team that's able to support the patients, ensure that if they don't have the care locally, not all teams have specialty on site. They might have an agreement to the community. They have a system in place to send them directly to get access to it quickly. But you have your pharmacy within the team. The pharmacist could be down the hall. It's pretty helpful. Like you would have your physio at on site. You would have your whole mental health team. You have, depending on some locations, some have the dental team on site, some not. In Ottawa, for instance, I have a floor, like it's 5 floor. Each floor has a specialty, not a specialty, but a team focus. But that's the team where we would hire more specialists. So you have surgeons on site, literally. You have dermatologists, you might have internists, you might have radiologists. And right now what they do, so for the radio, that's the same thing. They have a lab on site and you're imaging on site, which you don't always have access to in community. You might have to send them outside. So you can do everything directly at arm's reach. So most clinics are not operated that way.
So
It's
very
kind of a mini
well
hospital.
connected. Like the whole medical community is just very much in touch with each other in this environment.
Definitely about 85 different medical profession that may be there.
You spoke
That's-
before we started recording about the military family doctor network. I was wondering if you could explain a little more around that.
With the expansion of the Calgary Health team, so not just from our own physicians that we hire on contract, but also with one of our partner Primacy who operates clinics and they have a large networks of physicians. And knowing that is a community that we care for, given that our mission is to serve and support the national defense, and that we've created a program where it's an association and a matching system basically for physicians that can take on these families. So right now it's pretty much a 1-person team. And whenever a family is relocated to an area, like they don't have time to necessarily get on a list and wait sometimes years and never to be seen, where they're going to be located on that site for 2, 3, 4 years maybe. So we try to match them with a physician of the community that we might have that says, I could take that family for X amount of time if I can help. So the family would basically reach out and know how you have kids and what the needs are, what are your needs. And then that person will call around in the network and see, could you take these patients? And we just match them. And once the match is done, it's between them. So there's no billing associated. There's no fee or anything like that. It's more, if they want to be part of the network, they simply raise their hand and be like, I could take X family in this area. If they can take one, we're happy. So it has grown over the years. I would say like right now we've matched over 1,500 families. But there is a lot of areas still in the country that are not served by the program, unfortunately, given some restrictions we might see within the healthcare system, where sometimes there are some red tapes we really cannot cross. That would be helpful to these families, but I've experienced it myself. I was relocated to Ottawa and I was a military spouse at the time, and I waited 8 weeks to get a doctor. Like, that is incredible. And what a doctor.
Unheard of. Wow.
Unheard of. And they were apologizing
tough
for how long it took.
What?
No. 8 weeks, I'll take it.
That's amazing. Yeah, because the civilian physicians on the base, they're only seeing the active duty members. They're not seeing the actual family members, correct? So that's why they're sort of, they got to fend for themselves and find their own family doctor in the community, which would be very difficult if you're moving around regularly. Because it is. If you're on a wait list for 2 years.
Yeah, the level of stress just having to be relocated often, just knowing that whichever spouse has to stay at home a lot, it's hard to keep a job, it's hard to take care of the kids, you don't see your spouse a lot. So adding on that extra help is something that we thought it's definitely something that can be done to support and show appreciation for that community for sure.
And is that something that any of the family physicians or the other physicians just out in the community can sign up for to actually help out some of the active duty service members' families?
Yeah, it's as simple as there's a form. They can just send their contacts and the person will get in touch with the family. It depends. If they have no locations close to, then maybe not. But yeah, it's as simple as reaching out and then they just try to match you.
Very cool. Very cool. Okay. Well, if anybody is interested in getting in touch with you, wondering more about the military-based jobs, how can they get a hold of you?
They can get a hold of me. I'm on LinkedIn. I'm on social media. They can reach out through email. My email address is pretty direct. I have an account on Cherry Health. They can book a call with me to chat about whichever locations they are if they're interested. I have a cell phone. They can call me. I'm attending a lot of the conference, continuous medical education, like the more larger one, I would say. So I'm usually having a booth. If it's not me, it's going to be one of my colleagues in the West or in the East. And we usually try to be present. Or sometimes it's just if you know of a civilian or another physician working on a base, they might have collaborated with us at some point. So a lot of word of mouth happens when people are they know of a person and eventually end up on my desk. So
if you're interested, Miriam is everywhere. You can't miss her.
try to be. To the point of exhaustion.
Certainly,
Yeah.
if anybody out there is interested in more details, definitely check out the episode from Dr. Igor Ivanecki, getting the firsthand experience about being the civilian physician on the military bases. I guess before we close off, Miriam, do you have any other final thoughts or anything else that you wanted to put out there?
I would say there is definitely all sorts of options that are open to things. If it's not for you as a physician, there are different projects that we work on that might be interesting to different people. If it's just a matter of hearing about what those offers are and then just getting in touch, just get a hold of us and look into what we have to do.
Awesome. Okay. Well, Miriam, thank you so much for taking the time to chat this afternoon. Appreciate it.
Thank you so much, Jordan.